Hello, everybody. Thank you so much for joining us today. We are incredibly excited to share with you how innovation right here in British Columbia is saving lives locally and how that work is shaping bold global solutions in Uganda. I want to give you an idea of how today is going to flow. Dr. Gina Ogilvie will lead us through a presentation for about 35 minutes. And then we're going to hear directly from Dr. Carroll at the Uganda Cancer Institute. Now, I will mention it's very exciting that Dr. Carroll is joining us live from the ground in Kampala, Uganda. So that said, if Dr. Carroll is unable to find secure internet connection for today's webinar, we will ask her to join us with her video off. We also may present a pre-recorded video to you folks today from Dr. Carroll, filmed this past week, just in lieu of any technical issues. After that, we're going to open the floor up to a facilitated question and answer period with our team on the call today. And before we begin, I do want to provide you with a quick note on how to use Zoom during today's webinar. So you're going to see both a chat box and a Q&A box on your Zoom screen today. We kindly request that you use the Q&A box to ask questions for our presenters and our speakers today. That is where we will be gathering your information. And you're, of course, welcome to ask questions at any time throughout today's session. I know that sometimes we have a hot item in our heads and we don't want to hang on to it so we can really pay attention. You're welcome to pop those into the Q&A. I will circle back and get back to as many of those as possible during some dedicated time for discussion at the end. So I do want to take a moment to ground us in why we are here today. Cervical cancer is a preventable cancer. And together, we have the power to change the story from British Columbia breakthroughs to global impact, and from data to lived experiences, from prevention to possibility for every woman. This isn't just a program or a project, it's a movement that we are all here to shape. And each of you is part of that moment. By being here, you will see how BC-led innovation is already transforming lives. You'll hear stories from women and communities at the heart of this work, and you have the chance to help us shape the future, where prevention is possible everywhere. Your presence today is a huge step forward in eliminating a preventable disease, so truly, thank you all for being here. Now, we are so fortunate to have a very impressive group of women working together on this mission to eradicate cervical cancer worldwide, and we're honored to have all of them on the call with us today. In a moment, you'll be introduced to that team who will be available to answer your questions during the Q&A portion of this webinar. But with that, I'm pleased to pass this floor over to our keynote speaker for the evening, Dr. Gina Ogilvie.
Thanks so much, and just delighted to be here and have everyone have this chance to share some of the work that we've been doing over the past 2 decades, getting to the stage of my career where I can say that in looking at how to eliminate this entirely preventable disease. So I'm just going to share my screen right now. So I'm really delighted and pleased to present on behalf of Dr. Carroll and our global team here on how research in British Columbia is transforming women's health here in Canada, but also globally. And so who we are, the Aspire team is an interdisciplinary global team of passionate clinicians and scientists who arrive with great expertise and experience in women's health. We've been fortunate to work together for over 2 decades, many of us. And we've been really focused on women's health and particularly sexual and reproductive health with the elimination of cervical cancer in Uganda, in Canada, and globally. Throughout this all, we've been able to gather about $25 million in funding for studies, projects across both Canada and globally. And most importantly, and particularly with folks like Dr. Carroll, really working to shape the policy and to shape what the healthcare is based on the research we do. So that idea of our breakthroughs really making a change in the life of people every day. So who is our team? I'm privileged with Dr. Carroll to co-lead this team. Dr. Jackson Arem, who's the head of the Uganda Cancer Institute, and we've had tremendous support from the Uganda Cancer Institute who really believe in this work. Lori Smith, who I've worked with for now heading up to 15, almost 20 years, Lori is a nurse clinician and one of the global thought leaders in how to deliver HPV results to clients. And she's been at the helm of our team for a long time. Candice Ruck is our local program manager. Candice has been leading the Aspire team both here and in Uganda with Dr. Carol and myself, and we're delighted to have her join. And Priscilla, who's the local coordinator in Uganda. So delighted to be presenting this data on behalf of the entire team. So cervical cancer is a disease with global inequities, but also a disease with solutions. And to go back to Anna's phrase, prevention is possibility. It's not only prevention to possibility, but prevention is a possibility. And I think that's what drives us all. We know that prevention is possible. A quick look at this map tells you a story. And the story it tells you is that while all the world shoulders the burden of cervical cancer, some parts of the world shoulder it unequally. And you can see particularly South America, Southeast Asia, and Southern Africa, Sub-Saharan and Southern Africa, shoulder it to a much greater degree. And as I mentioned, cervical cancer is almost entirely preventable. It's preventable by vaccination, it's preventable by screening, and it's preventable by treatment. The thing about vaccination, which we're all hugely excited about, is that must be given to folks very early. They must be 10, 11, 12, prior to them being engaged in sexual activity. So most women are still at risk for cervical cancer if they didn't get the vaccine earlier on. We can detect the virus that causes cervical cancer. We'll chat a little bit about this for screening. And then the other very exciting thing is that we can, once we detect the virus and precancers, we can actually treat those, making it one of the almost entirely preventable cancers in the world. So because of this, both the World Health Organization, and then I'll talk a little bit about the Canadian Partnership Against Cancer, have named the elimination of cervical cancer as an achievable goal. For the WHO level, they want the world to have 90% of girls fully vaccinated. They want 70% of women screened with a high performance test, which means HPV, both twice in a lifetime. And for those who are positive for HPV and have a precancerous lesion, make sure the vast majority, 90%, get treatment. Here in Canada, we have similar but slightly higher goals, which is that we want 90% of all young people, not just girls, but all young people vaccinated with HPV by 17. By 2030, we want 90% of individuals screened with an HPV test. And then we again want treatment for those who are HPV positive. So let's just talk a little bit about this target. In Canada, we know that those folks women who self-identify as visible minorities, Indigenous, and who are current smokers and are from rural areas were overrepresented among women with invasive cervical cancer. And we also know that cervical cancer rate is significantly higher in First Nations women. You can see here it's almost double. So we have our own inequities here in Canada. And we know that most folks who develop cervical cancer are underscreened or have never been screened. And we know that about 66% of low-income of individuals and 62% of women who emigrated to Canada are up to date with screening. So we have huge screening gaps for folks of low income, for folks who are racialized, Indigenous, and who are new immigrants. So we've been passionate about this topic for many years. You can see our first work was done in the downtown East Side, offering self-collection so women can take their own specimen themselves to detect HPV. We started doing this work back in about 2004, and we published first in 2007. So it's really exciting now to see some of the work that started in its infancy in British Columbia expanding across the world. And this is the landmark study we led here in British Columbia that actually showed that the use of HPV testing was better than the traditional pap smear for cervical cancer screening. And this paper has provided the foundation for policy change, both Canada and globally, as we move this very large screening program from pap-based or cytology-based screening to HPV-based screening. And so in British Columbia now, we're very pleased after a pilot project that we led for 3 years, that in January 2024, we moved to HPV-based screening. And we moved particularly to cervix self-collection And we offer both self-collection or clinician-collected for cervical cancer screening. We particularly want to make sure we had self-collection in British Columbia because we know that reduces barriers to screening, particularly for those with a history of trauma or cultural sensitivity, for women who have difficulty accessing a primary care provider, have difficulty getting an appointment, or if they don't actually have a primary care provider themselves. So we anchored our screening program based on work here in British Columbia in a self-collection model. But as you can see, we really are committed to any place and getting screening for all women. So if you choose to have provider-collected screening, you want your own provider to continue to do HPV testing for you, you can absolutely do that. Or you can also request a kit to be sent to your home and do your cervix screening at home and return it through the mail. So it's a very exciting, transformative change that's been led here in British Columbia by science done here in British Columbia. And who's eligible in British Columbia? Anyone who is age 25 to 69 who has a cervix, including women, two-spirit, transgender, and gender diverse people who are due for screening, have ever had sexual contact, and is registered with MSP. So we're very excited that our science has helped to transform and shape the work here in British Columbia. But what about globally? You saw that map. You saw what was happening with cervix cancer around the world. And what are we doing to help change that? So now let's talk a bit about achieving this goal around the world. So how do we get the world to have 70% of screening completed? One thing I always like to talk about at this point is the sort of concept of cancer in low and middle income countries. I think many of us don't think about cancer in low and middle income settings. We think much more about communicable diseases. Those get a lot of conversation and they get a lot of play in the media. However, the truth is that low and middle income countries bear the majority share of the cancer burden. Yet, historically, significantly less research has been conducted in these settings. And it's really important when we do work from screening, treatment to palliation, that it actually be done in context to make sure the health system can actually adopt those findings and deploy them to the folks who are going to benefit the most. So there's an urgent need for cancer research is set in the low and middle income settings. And many of the health systems are not prepared to meet this challenge. So it's even more important to think about the health system in those settings when we do research. And so in global settings, as you saw on that map, despite the rollout of the HPV vaccine, low and middle income settings remain heavily burdened with all cancers, but particularly cervical cancer. And so our team is particularly interested in addressing cervical cancer because what the modeling has shown around the world, that if we can get 2 screens per lifetime among women, we can eliminate in under 30 years, 12 million cases of cervical cancer, an astonishing number of cases that can be prevented if we deploy this very effective tool widely. And what we're going to talk about is how do we get this effective tool widely deployed? How does our science help us to know how to do that best? I think the other reality is that when we think about women and we think about women with cancer, what we know, particularly in low middle income settings, and this is work that's been done by our team, Hallie Dow, who's a postdoc, now postdoc, but a PhD student with Dr. Carroll and myself, has looked at the burden and what happens when a woman has cancer. And what we know is there's a tremendous impact, not only obviously on the woman, her own dignity, her own health, and her own well-being, but also a much greater impact on her family, particularly her female children, in terms of school attendance, in terms of their well-being, in terms of their morbidity and mortality. Also the family income, job security, and then, of course, the community and community health. Women have huge roles, not only taking care of their family, but taking care of parents, in-laws, and their community. So the burden of women having cancer extends far beyond just the woman herself. And so what we know is that research inequities lead to health inequities, and we want to address some of those research inequities to address the health inequities. So as I discussed, we've had a long-standing, well-established partner between UBC, BC Women's, Makerere University, and the Uganda Cancer Institute. Uganda Cancer Institute works closely with the Ministry of Health to make sure that the research that we are doing actually helps to inform practice in country. And we've really committed to phased, pragmatic research that helps to design and evaluate pragmatic cervical cancer screening programs. So I've grounded our work in looking at self-collection for HPV-based screening. Self-collection is not only empowering for the woman, but it's very accurate, safe, painless, and it can be done anywhere. So women do not need to go to a clinic, and we also don't have to have practitioners do the screening. That saves enormous amounts of money for the system, particularly in settings that have very scarce resources. And it also empowers the women to be in charge of her own health. So why Uganda? I've had the privilege of working in Uganda for over 20 years. Uganda is a tremendously blessed country with enormously skilled healthcare practitioners, but it's also shouldered with some deep health challenges, including one of the highest cervical cancer incidence rates in the world at over 50 per 100,000. And at the same time, it has one of the lowest screening coverage, around 5%. And the WHO has helped to inform the national guidelines for Uganda. And here's some photos of our team as we're doing our work in country. And we also know that we have a baseline screening rate for cervical cancer between 4 to 30%, but on average, less than 5%. And the vast majority of women, 30 to 49, have never been screened. So this is a timeline for our work. We started in 2005, and you can see here we've done numerous feasibility and then large randomized trials, working in collaboration with partners to make sure the questions we're asking and answering are of deep relevance to the community. So how do we work? We work grounded in the priorities of Uganda Cancer Institute and the Ministry of Health, but it's informed by the women and by healthcare providers who tell us what will work. So in our latest phase of work, where we're working in rural and remote settings to improve cervix screening coverage, we really leaned on women and the healthcare providers to tell us what were some of the things that might support cervical cancer screening in these rural and remote areas, and what are some of the challenges. So some of the facilitators for screening was that women knew that there was a need for them to be screened. We knew that we had laboratory staff, like across Uganda, very skilled staff who were capable of leading and conducting molecular tests like HPV. These were deployed throughout the country already because of the HIV and TB testing. We had a lot of nurses and midwives who were very interested in skill development, so for those who were HPV positive and needed treatment. And we know that cervical cancer screening is a priority of the Uganda Cancer Institute. So when we think about moving forward with what does the country need to improve screening, these are some of the strengths we want to leverage. What were some of the challenges that both women and providers told us that we needed to be mindful of as we looked at screening programs? First, there is some misinformation, and we all are increasingly aware of the impact of misinformation. So in their setting, misinformation about some of the causes of cervical cancer. Challenges with transport. So how do we get women who are HPV positive and need treatment? How do we get them to the clinic? And how do we get those specimens? If we collect them within the village, if we do a village screening day, we have the specimens. How do we get them to be tested? There's a concern of quality of care, so we have to make sure we build the confidence of folks in community that the care they receive is excellent. There are long wait times because of high demand, and that's a result of human resource shortages, and also transport mechanism for laboratory. So these were some of the things we had to be really conscious of when we started to think about how do we design screening programs to improve screening with self-collection. So what we did was make sure to leverage and build some of the great infrastructure that is already exists in Uganda, including a network of community health workers. So every community has community health workers who are from that community, who know that community, and who are great a tremendous resource in engaging women in screening. As I mentioned, due to HIV testing, there are molecular platforms spread throughout the country, so we could leverage those. We have very experienced lab staff who do the gene expert testing, and also nurses and nurse midwives who are keen to learn next level skills in terms of treatment. There's a very sophisticated network of local health centers. And of course, we have partnership and collaboration with the Ministry of Health. So those are all the things that we built on, and we built all our programs with this in mind. So what have we done to date? We've trained over 50 staff, BHTs, lab techs, nurses, and doctors in cervical cancer screening. We screened over 8,000 women in rural and remote areas with HPV self-collection. We've provided treatment to the women who are HPV positive for cervical disease, and we have a very high treatment rate. So when you find out you're HPV positive, you need treatment. We actually have a very high engagement rate, in large part because of the engagement of the community health workers. We've worked hard to increase community knowledge and awareness of cervical cancer screening, and immunization. We've integrated HIV testing into cervical cancer screening. That's very important because cervical cancer is actually an AIDS-defining illness. So not everyone who has cervical cancer has HIV, but many people who have HIV and many women who have HIV will develop cervical cancer. So really making sure that we understand the HIV status of folks. And we've been, through Dr. Carol and her leadership and engagement with the Uganda Cancer Institute and the Ministry of Health, really informing the national strategy of what can happen. For instance, there was a concern as to whether a cervical cancer screening program could actually safely, effectively, accurately integrate an HIV screening program. And the Ministry of Health did a site visit with us, and now they understand that can happen. And so they're moving forward with that type of work. Here are just some beautiful shots of some of the rural and remote areas where we work. This is one of the screening tents and the education that we do in community. And here's our team, Candace and Priscilla, representing Aspire out in the country. So where do we go next? Our team has achieved very high acceptability for cervical cancer, but there's lots of women who have not been screened, and there's lots of ways we need to think of how to continue to do novel screening. So what our next plan is, informed by Dr. Carroll, by the UCI, by what they need, is a mobile same-day cervical cancer screening and treatment program. The idea behind this is when we do self-collection for HPV, what happens is we get the results to the women, and then they have to go at a later time to get treatment. Obviously, that takes a lot of work, energy, and with each break in care, you risk women dropping off. So, based on our partners and their advice and guidance, they felt that one of the most important ways we could do this, particularly for rural and remote areas, is to have a fully equipped cervical cancer screen and treat mobile clinic that's capable of providing this comprehensive village-based care in the most rural areas. And we view this, as does the team in Uganda, as a blueprint for how to contribute to the WHO cervical cancer elimination goal. And so the proof of concept is within this mobile clinic. We would have a clinic that day. All the women could get tested, rapid testing, and those who are positive can get screened and treated for precancerous lesion. This is just a mock-up. Dr. Carroll and team have helped to design this, and you can see there's a separate laboratory entrance where we can where we can do the testing. And then we have a separate consultation room, including a private dressing area, really providing folks with dignity and having women being able to be evaluated in this setting. Lots of guidance from our team around power supplies and axle load and all kinds of things. I think Candace has become a bit of an automotive engineer throughout all of this, but really exciting that this is moving forward. So what do we anticipate? We will anticipate that this will be a state-of-the-art diagnostic capability with a clinical and laboratory unit, train over 300 village health teams, provide point-of-care screening to over 30,000 women, And we'll provide same-day treatment for all HPV-positive women. So they're not lost to follow-up, the result of long distances, finances, family, work obligation, and also provide linkage to treatment for HIV-positive participants. So Aspire Reach, we plan for this to be a state-of-the-art clinic on wheels designed to navigate Uganda's most remote regions to reduce the barriers and provide same-day screening and treatment. And the model is sustainable, guided, and designed by our partners at the Uganda Cancer Institute for this project. And we believe this will be a blueprint for all low and middle income settings to replicate best practices to improve screening around the jurisdictions and around the world. So thanks very much for this time, and I'm going to hand it back to Anna.
Thank you so much for that presentation, Dr. Ogilvie. If you have questions for Dr. Ogilvie on today's webinar, please don't hesitate to use the Q&A function at the bottom of your Zoom screen. We will be collecting your questions and we will facilitate those questions to Dr. Gina as well as the rest of the team who are on our call today and see if we can get those answered for you in the amount of time we have. I would like to extend a very warm welcome. We do have Dr. Carol on the call with us today. Now, Dr. Carol is joining us all the way from Kampala, Uganda. I believe it is about 10 p.m. her time, so we are very fortunate to have her on the call with us today. She will be with us at the end of today's session during the Q&A, so you are, of course, welcome to ask Dr. Carol any questions you have about the work happening in Uganda. With that, I would love to present a very quick 10-minute video Dr. Carol filmed for us earlier this week. Dr. Carol shares a story of a woman whose life was changed in Uganda because of the Aspire program and the impact that this program is really having on the ground. I teared up watching it, and I hope that the rest of you enjoy. Let's have a look.
Hello, everyone. I'm Carol Metsuke from Uganda Cancer Institute. I'm a gynecologist working in partnership with Aspire. We have been together with Aspire for close to almost 10 years now, and thankful for this partnership because many women's lives have been saved. More than 6,000 women are dying every year from cervical cancer, and yet you and me know that it's preventable. Now, we have been in a number of districts, and recently we have been in Mayuge, which is the eastern part of Uganda, where we were able to screen women for cervical cancer and also integrate it with HIV, because HIV is still a burden with about 7% of women. So I want to give you a story about Sarah, not her real name. Sarah lives in Malongo, sub-county of Mayuge district, which is one of the most difficult to reach places in the forest reserve of Busoga. So she narrates her story, paraphrased, and says that VHT visited her in her home and told her about cervical cancer, how it can be prevented, and the fact that they were there to screen women for cervical cancer. And she went ahead and screened. So we asked her what prompted her to go ahead, and she said that she was having symptoms that had been mentioned, so she was concerned. And to have a doctor find her in her home, and she was told she didn't have to go to the health center, she could actually be screened in her home, she wouldn't miss this chance. So she went ahead and screened, and fortunately when the results came back, she was found to have HPV. She was positive for high-risk HPV. And so she was invited over for treatment. She came, but when she came for treatment, she couldn't be treated because she was found to have suspected cancer. Wow. That was a blow to her and to the entire family. She first kind of disappeared. Later, we found out that she thought she was going to die, so there was no reason why she would pursue any treatment. But immediately talked to them and encouraged them that this was a good chance. She could actually be saved from death. So with her husband and her family, they came together, they agreed, and with facilitation from Aspire, we referred her to the health center for it's called Chiganda Mega District. Biopsy was taken off, and to cut the whole story short, she was eventually operated on. She was found to be operable. She was operated on in Jinja Regional Referral. This is the referral hospital for South Eastern Uganda. She did well, was discharged, and the Aspire team accompanied her home. Now, when they reached their home, they were shocked. They found a big crowd of people in the house. Children, women, men. There were so many. So when they inquired what the issue was, to them, they were expecting a dead body. As far as they were concerned, who would have cancer, be operated on, and survived. So they had come for burial. So when Sarah stepped out of the car, there was total chaos. There was elation, there was jumping, there was a lot of jubilation. They couldn't believe she was alive. My team says they had to sneak out of the home because the situation was getting out of hand. But such was the happiness, not only for Sarah, not only for her family, but the entire community was excited. To date, Aspire is the name in Malongo district. They did not because they think that Sarah's life was literally snatched from the grave. They had written her off for dead. But Sarah is back. It's a rainy season, and they are happy. Actually, last week, I eventually met Sarah. I haven't seen a happy woman in my life for a long time. It felt so good to see the smiles, and she kept saying thank you and thank you. So I asked her whether she has attended her garden now that it's rainy season. And she said, yeah, she has no problem. She's strong, she's okay. And I was happy about that. Why am I telling you this? That your efforts didn't go to vain. You put a smile on Sarah's face. The entire community was happy because of Sarah. And this is just one person. There are others, many whose lives have been saved from having to die of cervical cancer. So thank you, Aspire. Thank you, our team. Thank you, friends, funders, donors. Thank you so much for putting a smile on not just Sarah, but on Uganda as such. That one woman and many other women's lives have been saved, so we are forever grateful. We are going now to the next part of the project. Cervical cancer is something that is not even known, but they are sick, they fall sick, they are bad, they are attributed to witchcraft, and so we are going to go to Butagaya. In the previous sub-counties, we used to drive the hire car, go to the villages, scream the women. That till then you would rush back. So every day it was back and forth, and the distance was far. It would take us 1 to 2 hours to get there every day. It was a nightmare during the rainy season. It doesn't have to be that way anymore. With a mobile clinic, we are going to pitch camp in the villages 3 weeks. And the women will come and go. They don't have to travel long distances to the health centers. They don't have to wait long for their results to come back. So we're excited and we're very optimistic that this time many women will screen and all those who are having the virus will be treated. We are looking at 30,000 women plus in the next 5 years. Now I am appealing to us, to our friends, You have made us smile in Malongo, make us smile even more. 30,000 is a good number, but it's just a drop in the ocean. So come and support us. Come and push us further. Not only are we going to screen the women for cervical cancer, we are going to screen them for HIV, and we want to make sure they get the ARVs. We also want, in addition, to vaccinate the young girls against HPV so that it's a comprehensive approach against cervical cancer. Join us in this fight. Join us and put a smile on men and women from the communities. Join us, support us, give more, and we are ready to work to the ends of Uganda. Thank you.
Well, I did warn everyone that this is a bit of a tearjerker. Dr. Carroll, thank you for taking the time to speak to us about what everything looks like over on the ground in Kampala. And as I said, we are extremely fortunate to have Dr. Carroll with us today. So with that said, I'd like to just go around and reintroduce the team that we do have on the call so that folks who are interested in asking questions can pop those questions in the Q&A. And I will begin facilitating a question and answer period for the team. So without further ado, again, requires no introduction, but Dr. Gina Ogilvie, our keynote presenter today, is on the call. Dr. Carroll is on the call. Dr. Carroll, if your internet is stable enough and allows you, you're welcome to turn on your camera and give everyone a big wave, a big smile. We also have on the call today Laurie Smith. Laurie Smith works directly with Dr. Gina Ogilvie. Hi, Laurie. Thank you so much for joining us today. And of course, we have Candace Ruck. Candace is also working directly on this project in Eastern Uganda, very well versed in the logistics. As Gina mentioned, she's become a bit of an engineer, so don't hesitate to ask your engineering questions as well. Dr. Carroll, so lovely to see you. Thank you for staying up this evening to join everyone. Now, I will have an eye on the Q&A. Please feel free to pop your questions in there at any time. We will facilitate this for about the next 10 minutes or so. And we do have one question that was asked a little while ago, actually. And Dr. Gina, I think I'll throw this one over to you.
Yeah, thank you. Yeah, and thanks, Nick, for this great question. And I think just so we really explain it. So what happens with screening, which is the HPV testing, is we're looking for the presence of the virus that causes changes. What happens is if you have an HPV infection, you can then go on to develop what we call precancerous changes on the cervix. And those are detected by looking at the cervix. You put some acetic acid on it, you put a light, and we can actually treat those. So treat precancerous lesions with either, in Canada, we would excise it or cut it out. And in Uganda, we do something called thermal ablation. So use heat to destroy those cells. So there's HPV, where women self-collect, they get identified as having HPV. We then have them undergo something called a visual inspection, where we look for these precancerous lesions, and that's where we put a bit of acetic acid, and we treat those with thermal ablation. That's what we call that's going to be our same day treatment. The vast majority of women, that's what they need. There's a small percentage, like the women Sarah, and this is what we want to prevent and why we want to screen early, is there's women who then go on, if it's missed or not screened, they go on to develop those precancerous lesions, become cancer, and then those women need surgery, hysterectomy, and hopefully we can catch it by then. Sometimes we catch it too late, it's already spread, and then the only thing we have to offer is palliative care. So that, if you need surgery and if you need care beyond that, that's not the same day. But the same day is that very effective treatment of precancer, which will prevent the progression of precancer into cancer. Laurie, Candace, do you want to add anything?
I just wanted to add, thanks, Gina, that since you talked a little bit about the BC landscape and where we are in Canada right now, too, I just wanted to add it's a little bit different here in British Columbia if a person tests, if HPV is detected in their sample. First, just to let folks know, HPV is highly prevalent. It's quite common. And just because someone does have HPV found in their sample, it doesn't mean they have or will develop cervical cancer. And in British Columbia, that treatment pathway is a little bit different. So it depends on the kind of HPV that is detected. And a person may need follow-up with just a pap smear or going to a clinician to have a look at the cells of the cervix, or something more diagnostic like a colposcopy, where we have a closer exam of the cervix and a little biopsy is taken. Again, just to emphasize that seeing HPV in a sample doesn't necessarily mean someone has or will develop cervical cancer. It just means let's look at this person a little more closely and follow them along the way.
Thank you, team. I will jump to another question here. Lori, you mentioned the case in Canada. I'd love to ask you, if someone does want to access a self-screening kit for themselves or for a loved one, how can they go about doing that locally in British Columbia?
Yeah, great question. I think we are going to share some links at the end of the session here. But if a person is eligible and due for screening, there are links on the BC Cancer Cervix Screening website where a person can email or call and request a kit. Of course, a person has to be due for screening, so they can't have had their screening in the last 3 years. And when you contact the screening program for your kit, they will go through a few eligibility questions to make sure you're due. Alternatively, there are some clinics in the province, if a person has a provider, that they have the kits on hand. So it's really talking to your provider if you have one, or reaching out to the screening program.
Thank you, Laurie. Shifting back to the work that's happening global in Eastern Africa, Leslie has a great question. Will you be able to do this treatment in the mobile centers, in the vehicles themselves? And she also adds, thank you for this amazing work that the team is doing.
Thanks, Leslie. Candace, I'll let you start with that response, and then I'll follow up. Yeah, go ahead. And Candace has been amazing with Dr. Carol, as they've basically designed what we need in the van, and to make sure we can cover all our bases. So go for it, Candace.
Thanks. Thank you, Gina. Yeah, the mobile clinics have been designed to be a combined lab and clinical space. So the lab component is so important for us to have our lab equipment in the field with us, so we can do same day screening, or like test the samples as soon as they're retrieved. But then the women will wait in some of the tents that you saw in the photos we showed. While those results are prepared, they'll be available in 60 to 90 minutes after sampling. And then the women will then be directed into the clinic portion of the mobile vehicle to have the visual inspection done. And if they have the presence of precancer, if they haven't progressed to cancer, in that mobile clinic there, they'll be given the thermocoagulation to treat the precancerous cells, to stop the progression to cancer. So that form of treatment, the precancerous treatment, will happen in the clinic on the same day. It's only those few women who've already progressed past precancer to suspected cancer that we will then need to refer on to a health facility for more advanced care.
And thanks, Candace. And so part of what Carol and Candace have spent a lot of time doing is making sure that the van can accommodate that. And Leslie, just because I know your background and experience, you'll be interested to know that treatment is by and large done by nurse midwives. So Carol does the training for them, and it's visual inspection with acetic acid. So with vinegar, they assess where that lesion is and do the treatment. But that's all done by and large by nurse midwives as well.
Wonderful. Thank you, team. Keeping on the subject of the work happening in Eastern Africa, one of our questions here is that cervical cancer, as you mentioned, is almost entirely preventable. And as Dr. Carol alluded to, many women are still dying from this disease. Are you able to speak to why this has been overlooked until now?
Oh, that's such a good question. I think there's a bunch of layers to that. I'm privileged to be the Associate Director of the Women's Health Research Institute. I work with the BC Women's Health Foundation and the BC Women's Hospital. Why do we need a Women's Health Foundation? Why do we need a Women's Hospital? Because traditionally, women's health has been ignored. It is not taken seriously. We know it wasn't until sort of the 90s that women were routinely included in randomized trials. And we know that there are very different female responses to even things like migraines or ADD diagnostic treatment. And then there are female specific conditions that have also been ignored. So there's that history of not prioritizing women's health. So there's that overall. I think also, though, in fairness, there was a feeling, and I talked a little bit about this, that cancer isn't an issue in low resource settings. It's all communicable disease. And we know that now chronic diseases, and particularly things like cancer, but diabetes, et cetera, those are all having very big impacts in low resource settings. So that's the second thing. I think people didn't think cancer. I think the third thing is that we have these now great developments. We have a vaccine that works, and we also have screening that can be deployed very effectively without the need for very complex infrastructure. So that's why our team has been so passionate about this since these innovations were developed, because we immediately saw the opportunity to really be a game changer. I think the final thing I want to underscore is, when you keep a woman healthy, you do it for her, obviously her own self, her own dignity, her own well-being, her own quality of life. But it is for those with the economic interest, it is a massive bang for your buck in terms of your investment. Because when a woman is healthy, her family's healthy, her family gets educated, her girls go to school. And we know that women's health is the greatest predictor of family health. Family health is a predictor of family wealth, and family wealth is a predictor of economic wealth. So investing in women's health overall, and particularly things like cervical cancer, which have highly effective, highly cost-effective, and impact women in their reproductive years, by investing in that, you really transform the lives of not only these women, but their family, their children, and their communities.
Well said, Dr. Ogilvie. Thank you. And it segues beautifully into the next question, which is, what will success in Uganda mean for the global elimination of cervical cancer and for the legacy of those who invest in it now?
Yeah, I think the most important thing for that is that how we do our work is we start with policymakers right from the beginning. So you remember that slide I showed you that said, what did healthcare workers want? What did the women want? What were their concerns? By answering the questions and also integrating. So for instance, using one of the things, for instance, we do is we use the molecular platform that is available across Uganda. So what Aspire is doing, and uniquely doing, is that we are grounding the work in very deployable, immediately deployable interventions. So the country can roll things out right away. So we're also situated, so we're not, taking lessons from a rural part of Canada and saying, hey, let's do this in Uganda. We're working in country with the leaders in country, with Carol, with Dr. Orem, with UCI, to say, what do you need? What's the evidence you need to deploy this, to activate this work? So what does it mean? It means that they have the evidence, and they have the absolute relevant evidence and experience to actually deploy this farther.
Thank you. And we knew we'd get at least one engineering type question. So Candace, brace yourself. What contingency do you have for vehicle breakdowns with Aspire Reach in Uganda?
Yeah, so that's a great question. So that was kind of baked into our design process from the very beginning. We are building the vehicle through a designer in South Africa so that they're fairly familiar with issues of local terrain and local conditions. And again, throughout the whole design process, we really wanted to consider, when we're out there in the middle of rural Uganda, what would be our contingencies if we had vehicular breakdowns. So first of all, we selected a base model of the vehicle that would be quite easy for a mechanic with sort of basic level skills and tools in the field to be able to work on. We didn't go for one of the more sort of advanced type vehicles that had a lot of complexity to it, required a lot of difficult to find parts. We also sourced a vehicle that has suppliers and service mechanics in Uganda. So again, we will have local people will be able to work on it, and supplies should be easy to source for it. So if we are in, rural areas of Budagaya, for instance, and the vehicle breaks down, we will be able to bring out a mechanic who will be able to work on it if it has a fairly complex problem. But we are also hiring drivers who for the vehicle who have mechanical skills. So more basic problems will be able to be dealt with on site by our own staff. So those are all contingencies we have built into both our design and our processes to deal with breakdowns, both in the field and larger breakdowns as well.
And Candice and Dr. Carroll have spent a lot of time with the designers around sort of things like the axle load and the tire size. And so it's all been grounded in those sort of high grade vehicles that go over rough terrain. So one of the things when you work in low resource settings, there are a lot of those vehicles that are very robust in a way that sort of some of our vehicles aren't. But we've really focused on a vehicle that's very simple, very reliable, has sort of the axle load, the strength, the capacity, the capability, but also can be fixed also very easily.
Thank you, team.
I told you she'd become an engineer. I told you that.
Okay, Leslie has another question for the team. How will you map out where you're going to go first and the routing and priority in Eastern Africa?
Candice, I'll let you start that.
Okay. Actually, you know what? I'm going to throw that one to Dr. Carroll if she's able to, and then I'll follow up after her. But Dr. Carroll really has the local expertise, so she's really, I think, guided a lot of those decisions for us.
Carol, did you hear the question, Carol? So just how did you decide, or how are you going to decide what order we're going to go community to community?
Thank you so much for that question. I hope you hear me. Do you?
Yes,
you're very clear, Carol. Thank you. Yeah, that's great.
Great, thank you. So we went to the local communities. We have data. It's not so accurate, but we have some data from UCI. And normally we see where a majority of the cancer patients are coming from, which districts they are coming from. And we also compare to development in those districts and what access they have to healthcare. For example, Mayuge does not even have a hospital in the entire district. The best facility is only a health center and it seemed to be the most disadvantaged as far as Eastern Uganda was concerned. So we thought that was one place that would benefit. And indeed, when we got there, cervical cancer was unheard of, nothing, not even in the facilities that had been screening. So after we are done with Mayuge, we wanted now to move to the next disadvantaged district. And again, we always use data. It may not be accurate, but again, we use data to guide us to what. So we to Jinja district, and when we had the meeting with authorities in Jinja district, we inquired from them where they thought the need was at highest, where they had the highest need for screening. They guided us to Butagaya. So we plan to cover entire district of Jinja, but we shall go sub-county by sub-county and go again to another disadvantaged place. So we are usually guided by data and then the local communities, and we also take time to visit these places and we compare notes and see where we shall have the best impact. Thank you.
Thank you,
Thanks
Dr.
so much, Carol. That was great. Thank you.
Candice, did you want to add on to that?
No, I think Dr. Carroll really captured our process for us there.
Thank you. Thank you, Dr. Carroll. Our next question for the team is why Uganda? Why is this country your proof point for this work? And how can success here accelerate the elimination of cervical cancer in other low and middle income countries?
Yeah, maybe I'll start. So we've been working. Carol and I started working together about 12 years ago, but I've been going and working with the Uganda Cancer Institute and Ministry of Health since 2006. And it's partially some of the stuff we've spoken about. One, it is a country that is very representative of Eastern Africa, West Sub-Saharan Africa, with a high burden of cervical cancer. And I showed you the map, and that picture tells you it all. At the same time, it's a country with very experienced health professionals, community health centers. So again, very exemplar of a lot of the jurisdictions that we hope to work with. But so that's part of it. And then we think that the lessons learned, the integration with policymakers is really valuable because we can show what happens once you get research and you can deploy it out. So I think there's a lot of reasons. And the other thing is our great partners want us there, and that's another very critical reason. So
thank you, Dr. Ogilvie. We have time for a couple of more questions. We do have a couple in the docket, so I'm going to go through in order in fairness of the use of our time. We have a question from Greg who says he's reluctant to ask. However, he's wondering if such the times we live in, if the program is affected at all by changes in USAID.
I mean, there's no one around the world that hasn't been affected by USAIDs. So that's for folks who don't know the cutbacks and closure of the large aid organization from the US. USAID funded PEPFAR, and so that was one of the most important projects for funding antiretrovirals. So I know Carol and Candace had to deal with some urgent changes where there was concern about access to ARVs. That program has been sort of reinstated. I think it's a lesson for us all, and this is why I think we're so excited. The support from BC Women's Health Foundation and from all of you to support this work is we all have a responsibility to support this work. We all are global citizens, and we all can play a part. And having family foundations, private donors, research dollars, all of that work contributes to addressing some of the research inequities that we've talked about. So yeah, Greg, for our specific project, we're fortunate that we're funded by a variety of sources, including the generous support of donors like folks on this call. At the same time, it's important we keep that open because USAID has shown that we need a variety of people stepping in to step up as global citizens.
Thank you so much, Dr. Ogilvie. With that, I do want to conclude our Q&A, but the conversation does not stop here. We will share a couple of links with you in the chat where you can learn more. I will share my screen as well. We have a QR code loaded for you so that you can learn more and also find out how to contact me and the team with future questions. Of course, I want to extend my deepest gratitude first to our incredible speakers, Dr. Ogilvie, Dr. Carol, Lori, Candace. Thank you so much for joining us and answering the questions today. And also each of you who attended, thank you so much for taking the time to be here with us. I think what we've seen here today is that success in British Columbia is really proving that elimination is possible everywhere. And by bringing together that innovation, that research, the lived experiences, we can really change the story of cervical cancer, both locally and globally. Your interest and presence today are already a part of this movement. And if you do feel inspired to take the next step, whether that is sharing what you've learned today, connecting with me directly, connecting with the team directly, or supporting our global efforts, we would absolutely love to walk alongside you in making prevention possible for every woman everywhere. Thank you again for being a part of this really important conversation. I think together we're really proving that a future without cervical cancer is within reach, and we really hope you have a great rest of your week.